Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, friends. Happy New Year, and welcome to this first episode of the Healing Pain Podcast in the year 2021. We are starting the year off on a strong note with one of the world's experts with regard to pain neuroscience education. My guest this week is Professor Adriaan Louw. Adriaan is a physical therapist, a pain scientist, and author in the field of pain neuroscience, and the director of the Therapeutic Neuroscience Research Group and director of pain science for Evidence in Motion. His main area of research focuses on teaching patients and healthcare providers more about pain. He has more than 20 years of experience teaching pain neuroscience education to health professionals. He's authored numerous books on the topic and published over 70 peer-reviewed papers related to pain science. On today's episode, we discuss Pain Neuroscience Education Plus, why pain neuroscience education is important for both practitioners and people living with pain, what types of clinical outcomes you can expect when you deliver effective pain neuroscience education, and whether or not pain neuroscience education should be delivered as a standalone intervention or part of a larger multimodal treatment approach coupled with other cognitive interventions such as cognitive behavioral therapy, acceptance and commitment therapy, or mindfulness. Throughout today's interview, we discuss how you can effectively use pain neuroscience education and couple it with other cognitive interventions. If you're interested in combining pain neuroscience education with acceptance and commitment therapy, make sure to check out my latest book available on Amazon today. It's called Radical Relief, A Guide to Overcome Chronic Pain. Inside, it goes deep into the principles of acceptance and commitment therapy and includes over 50 cognitive and mindful exercises you can use with your patients, as well as just a little bit of pain neuroscience education. Okay, without further ado, let's begin with the great Adriaan Louw. Hi, Adriaan. Welcome to the podcast this week. It's great to have you here. Thanks for joining me.
Hey, Joe, it's nice to be here finally.
Yeah, I've been looking forward to talking to you. As one of the leaders in pain education globally, it's a real pleasure to be chatting with you. I know people are going to be interested in the things you have to say and the information you have to share. I had the pleasure of hearing you speak a couple of years ago at the International Association for the Study of Pain, and I really enjoyed the lecture. Lots of great information on pain neuroscience education and pain neurobiology. Really enjoyed it as a practitioner. There's something that you continually seeded throughout that lecture that has always stuck with me. And throughout that lecture was a room of, advanced practitioners with DPTs and PhDs, and some of the world's best were in there. But you kept saying, please don't use technical and high-level words and vocabulary with your patients and with the public in the delivery of pain education, if you will. And that really always stuck with me because I think pain is, as we know, the study of pain is complex, but we want to deliver it in a way that's easy and approachable and digestible for people. So I think it's appropriate that we start today talking to people who have pain because they do listen to this podcast. And in your own words, how would you describe to people living with pain why it's important to learn about pain and how it can help them recover and lead a better life?
Yeah, that's a good question. I think it's ultimately important for people to understand what's going on with them. If you woke up this morning with something wrong with your knee, you would like to know what's going on. It's kind of the old story, right? I'm going to know what's wrong with me. What can I do for it? What can you do for me as a provider? And then how long will it take? And even will it get better? The reality is, Joe, no matter where we look at it, when people come to us as healthcare providers, they want to have answers. And we do give them answers. The problem is just sometimes these answers are so advanced that patients don't understand it. And it doesn't mean it's a fault of the patient. It's our fault. A good example is you might as well speak a foreign language. The language we have is so complex and so, we try and impress people. Where the best evidence says take complex and make it simple, where a patient on any level can go, I got that. I mean, we're seeing it right now. We're doing it in middle schools. We're teaching middle school kids about pain, where they sit there in the classroom and go, I got that. Mm-hmm. And so why should people learn more about pain? Because pain is a universal human experience. The sad reality, there's about 12 people in the world today from a condition called Mendelian disorder that cannot process pain. Pain is important. Without it, we would be dead. It protects us. And so fundamentally, we must understand it. So my answer to people struggling with pain is, why should you know more about pain? Because it's your pain. And I would like to know what's going on with me if I was in this position. And I often do get in these positions of pain myself. And we do know now from a robust bunch of research that if you learn more about your pain, you're better for it on many levels. You're less fearful. You're less anxious. There's so many positives as to understand. And same thing, I would like to know what's wrong with my car. And the minute I understand what's wrong with my car, I'm like, oh, cool, now I know what to do about it. And that's almost that simple in some way, if you will.
Yeah, it's a great way to start the episode. And I always want to, when I started this a couple of years ago, I really approached this as a public service announcement for people living with pain and, of course, practitioners as well. So I always like to, touch on that aspect of it for the people listening. But one of the reasons why you came on my radar a couple of weeks ago is there was a viewpoint in the October 2020 Journal of Orthopedic and Sports Physical Therapy. We'll link to it in the notes so everyone can access it. The title of that viewpoint was Revisiting the Provision of Pain Neuroscience Education, an adjunct intervention for patients, but a primary focus for clinical education. So viewpoints are scholarly papers that contain an opinion or perspective from someone that's relevant to, let's say, a particular profession or a particular topic that is out there in the field. Why did you decide to author this viewpoint at this time?
Because our understanding of pain neuroscience education, teaching people about pain, fundamentally shifted in the last year. And what we've also started figuring out, Joe, is a lot of clinicians have either we have done a very bad job at presenting this content, or people have misinterpreted it. The idea that I could sit with you and in some miraculous way explain pain away from you, and suddenly like, hey, I'm better. It's way more complicated. Pain education is good, and it's a very good strategy, but in itself, it's very limited clinically. If you look at the current research, right, education by itself in any healthcare setting is not that powerful. In the United States, we're spending $2.1 trillion on smoke cessation. And we cannot print large enough on cigarette packages, smoking causes cancer, and people smoke. So education doesn't change behavior as much. It doesn't change pain that much, for that matter. I mean, I wish I could do it, but we, as a research team, started looking at all the data, and it just became so apparent that P&E, or pain neuroscience education, by itself isn't that powerful. Actually, the original title was P&E Doesn't Work. And now the editors decided not to put that in because that they wanted to create a little bit of a stir that people need to understand, because some people think that's what we do. Pain neuroscience education is better seen as a primer. The evidence behind movement helping pain is astronomical on every level. You and I can have a serious conversation, and I know this is an area you're very good in too, that there's various forms of movement. There's aerobic, there's traditional, non-traditional, etc. But people in pain won't move. Why? They're afraid. They're nervous, they're anxious, they have catastrophizing ideas related to movement. And what P&E does, it normalizes that. Then you move, and what made you better? Movement, not P&E. P&E made you move. And I think if we wanted therapists, clinicians to read and understand that this thing they've been doing for decades and decades works, is just a means to get people to move. And that was the intent behind it.
So it was a way to clarify and update the research and to help provide a guide for practitioners on how to use P&E and what it's useful for and what it's not useful for.
Yeah, I think it's just a right sizing of the ship. And the neat thing is I'm one of many authors. And when Corey Zimney, who's one of my colleagues, and I sat and discussed this at a conference, it just was one of those light bulb things we started looking at. And then we contacted other very well-known scientists in the area, Dr. Joe Neese, Dr. Kathleen Sluka, Carol Courtney, and said, this is what we are thinking. And they all like, yes, absolutely. So we got together as a collective team and said, this is a message that's worthy getting out. That I don't want clinicians to think you can just bring a patient and sit them at the table, explain to them how pain works, and suddenly they would stand up and say, I'm pain-free. It doesn't work that way. Pain's way too complex.
Right. So without throwing the baby out with the bathwater, tell us what the advantages of P&E are with regard to clinically meaningful outcomes. And I guess, I don't know if we should break that down first into P&E as a standalone treatment, and then P&E combined with what you call P&E plus, which, as your so eloquently stating, the purpose of P&A, like the first plus we should add on should be some type of exercise, movement, or physical activity. But as a standalone treatment, are there any advantages to it?
Yeah, I believe so. I think we're still in the early stage of figuring that out. We do know that P&E today has a robust effect on two things: fear avoidance and catastrophization. So if a patient were to come in our clinic and they had high levels of fear, which we can measure, high levels of catastrophization, which we can measure, P&E would be not a bad intervention to ease some of that. But again, it makes a move, right? That's the intent of the treatment. So there's nothing wrong doing it. I just want clinicians to not think of it as a standalone. It's the aha moment. It doesn't work that way. So, but I do. If patients walk in with high levels of fear of catastrophization, I would definitely consider P&E as an intervention. Which brings in the idea again of who does not need P&E. You know, it's funny, Joe. I've been interviewed about P&E for the last how many years? Nobody's ever asked me who does not need P&E.
It's one of my questions, actually.
Who doesn't need it? Well, guess what? If you have what we would consider nociceptive dominant, right? You have an ankle, you have a back, tissues that are not happy, but you're not afraid, you're not fearful. It doesn't, make you not see the future as bright. You're like, it's an ankle sprain, I'm good. You don't need a cognitive intervention. We just need to get your ankle moving and get blood flow, oxygen, and life is good. Also, we do know that P&E is not needed for people in pre-contemplation phases. If you look at the readiness of change scale, I've said it for a long time, and there's good data to back it. When people come to us in pre-contemplative, and those are people with the utmost respect, they're not ready to change yet. My brother is one of them, right? He's a smoker, and every year I visit him, smoking causes cancer, and he's like, forget you, whatever. In the therapy realm, patients come in and say, I'm only here so that, I keep my employer happy. I'm here to keep my wife off my back. As an example, we will teach students, don't try a cognitive intervention. They're not ready for it. Let's do some really good movement-based stuff, treat them with compassion, dignity, respect, and then as they shift, we can do those. So that's the answer. The P&E plus, correct. The idea is that P&E by itself is not powerful. Actually, most treatments in general by themselves are not good standalone. We now know, you and I can speak the same language, right? If you manipulate somebody's neck, that's good, but you got to surely show them some exercise and stretches. And so I would argue the same kind of a process would work its way through. So movement, sleep hygiene, nutrition, things you are, very well versed in, can be added to the approach.
Yeah, that's an important point. I talk to practitioners all the time about that. Like just one intervention, like if you find yourself being hooked by just exercise or just nutrition or just manual therapy, and that becomes your mainstay, then you probably need to just step back and, reflect on your own practice and reflect on your own skills and look at yourself and say, okay, where am I being effective as a practitioner and how can I improve myself and be more effective? What's missing from my skills as a licensed professional? And the purpose of continuing professional development is that you professionally develop throughout your career. And there's really no end to that for professionals. Okay, just to summarize, P&E has an impact on pain catastrophizing. P&E has an impact on kinesiophobia or fear of movement.
Yep.
How about pain and how about disability?
Not much. We don't have great studies to show that it robustly changes pain. The minimal detectable change of pain, typically it's about 2 points on a 10-point scale. I have not seen much research to show it can do that. But think about it though, Joe, the idea of pain neuroscience education it just normalizes the pain experience. You understand it more. It's actually, to be honest, there's a condition that we've alluded to it in some of our papers called explain pain. When we teach people about pain, the pain actually gets worse. And what I mean worse, relax, it's 0.01 on a 10-point scale. It just slightly goes up. And we have tracked those patients and they actually do better long-term why does it happen? Because they think about it. And if you think about your pain, you're more aware of it. So you may rate it slightly higher. So pain doesn't drop suddenly. Function also not, which is really intriguing for us. We've been on this incredible journey trying to find out what does pain neuroscience education do? We know it's fear and kinesiophobia. Self-efficacy is big on the scale. Those kind of things we're looking at right now. But I wish I can say robustly it shifts function. It does, not as much as we wanted to. So, yeah.
Mm-hmm. Great. And you answered this question just slightly, but I want to come back to it because I'm sure professionals want to know. Is there a diagnosis, a group, a population, a demographic that would benefit from P&E more than the other, beyond those just with pain catastrophizing and kinesiophobia?
Yeah, it's been studied, and right now, as I close my eyes, I can see the list. There's a handful of conditions that P&E is ideally designed for. People with central sensitization or nociplastic pain. This is widespread sensitization of the nervous system. They do well with this approach, as they do well with any cognitive approach, be it a CBT, acceptance therapy, etc. People with chronic pain, and when I talk about chronic, I'm talking duration. And I understand some chronic conditions start very early, but it's the longer you've had pain, the more layers we start adding to this, let's call it onion skins model, if you will. Yes, fear and catastrophization do well. And then, as I mentioned, people that are in the readiness for change scale, they're ready for shift. They're in the preparation phase. Those kind of patients do well. Specific diagnoses, it's been studied extensively on things like chronic back pain, fibromyalgia, chronic fatigue syndrome, chronic whiplash-associated disorders. We've done it on pre-op patients for various orthopedic surgeries. But that's probably the bucket we would be looking at for people that tend to respond well to this.
So let's talk about P&E plus. And as I look at all the different types of cognitive behavioral interventions that are now, kind of bubbling up to the surface, pain neuroscience education, ACT, CBT, mindfulness, I mean, you can go down the list of things. I feel there's been a focus on pain. Mm-hmm. And what I like about your viewpoint is you're bringing the focus back to movement, physical activity, meaningful activities, et cetera, which in my opinion should be the ultimate outcome of all this. So yeah, of course we want pain to go away. We want pain to decrease substantially. But I've always been more interested in, I don't know, from a child, I guess because my mom was a nurse and she worked in a hospital, and I had access to people who were kind of suffering, but still living life with pain. So my curiosity has always been, no matter what stage of life someone is in, how do we help them engage with that life, even if they have some pain? And I think that's really what you're saying with P&E plus.
Yeah, I think so. The idea would be that, like you said, there are today people with chronic pain starting their PhD that's getting ready to run a marathon. Obviously, during COVID, right? But the point being, there are many. This is the thing that really excites me: is there are people that have chronic pain, significant, but function at very high levels. And that has always intrigued me. Why is that? Is it self-efficacy? Is it goals? Those kind of, we need to change. That's the paradigm. And what P&E Plus does, it's this idea of there's so many ways of making a human being better and healthier. Be it sleep, be it nutrition, be it exercise, be it mindful, be it, relaxation, breathing. I mean, Joe, the first thing I was taught in PT school way back in whenever I went, right, years ago, first day PT class, I was taught breathing. I remember sitting there thinking, stupidest thing I've ever done in my whole life. And here I'm sitting almost 30 years later going, let me tell you about breathing. One of the coolest things you can do for somebody in pain, right? So you talk about professional development, but how neat is it? I want clinicians that listen to this understand they currently have a plethora of techniques to their disposal that they already have. P&E just helps people do it a little bit, more willingly, if you will. So people always say, well, I'm not a pain specialist. You don't have to be a pain specialist. You just have to be a caring provider that can, for some people, teach them how to sleep a little bit better, get some better habits going. Maybe you know something about nutrition. You can help them. If not, get them some help. I mean, I think we have so much in our wheelhouse already. The problem we've just had is people in pain, we have to get them to engage in those. And that's where these cognitive approaches, P&E is one. I mean, CBT is, as you mentioned, right? Acceptance and commitment therapy, motivational interviewing, the list goes on and on and on, is just to move the needle somewhat. So people like, I could do this. And there they go. And then you pick your path. I love the P&E Plus thing is really neat though, because you know what I do in a clinic? I give people that list and I say, pick one. Now suddenly our patients have a choice. Yeah. And the cool thing is to say, oh, what's mindfulness? Well, let's tell you what it is and let's show you. Oh, what's sleep hygiene? Let me show you that. And we give them the choice. And instead of just there's a protocol from A to B to C to D, which that's why I think clinicians get so tired, because I have a protocol and you don't follow my protocol. Well, pain shouldn't be a protocol. Pain is a human lived experience. So, yeah.
Well said. I want to go back to the idea of education for a minute, but I want to turn to DPT school. And I'm curious just from your own perspective, I know there have been guidelines by the International Association for the Study of Pain that some schools have adopted, some schools have not adopted. Just if we look at exploring P&E and education programs, some of that research is lacking. So we need more research in that area. Do you have a suggestion to a university DPT program or an OT program or any kind of program with regard to should P&E be a single class? Should it be a single course? How many hours? How do we measure outcomes with regard to professionals learning this? Do we need to have more on, let's say, the PT boards? A lot of kind of different topics there, but they all kind of connect to the same root, I believe.
Yeah, that's a good question. Obviously, everybody should realize I'm super biased, right? So the good news is, we cannot stop traveling from school to school. That be a PT, OT, nurse practitioner, medical school, etc. There's an enormous hunger for this content, so that's good. You and I know, Joe, that whenever we introduce something new, it takes what is the quote 17 years or something to work its way in, unless there's something drastic, it shifts you, right? I'm pretty happy to know right now that P&E is filtering its way through PT schools. Every year at big conferences, people like myself, people like you are up on stage just telling people all this. So the young generations are getting exposed to it. As an academic person, the question is always, what do we take out? Right? And that's the always classic kind of a thing. The good news is P&E is working its way in. I know that it's under review for CAPT, that sets a lot of the PT guidelines for us. I know more and more schools are putting it in, even if it's not a guideline yet. So it depends, right? It's like manipulation. Some schools teach one manip and say we covered it, check the box. Another school does lumbopelvic, and then another school does everything manip, whatever, depending on the bent of the instructor. Good news is it's moving in. The guidelines from the IASP are really good guidelines, and we're actually discussing with Kathy Sluka and her team this idea of should we follow up with that study that was done 5 years ago? Has the needle shifted? I think it has. That's a good part. Now, your question to me is, as far as a class, those are tricky. There's some data that would show that around that 15-hour, classically 2-day weekend seminar type of hours from Latimer's work has shown seem to be the optimal amount of pain science. A few years ago, University of Wisconsin invited me. Bill Boysenald was still there before he went to the APTA, and they invited the faculty, brought me in, did a lecture, and they asked me, if you had to build an ideal pain program, how would you do it? And my answer was, yes, you can do P&E as a standalone, but it should be filtered in the whole curriculum. It should be filtered into orthopedics, neuro, amputations, pediatrics. But I'm biased, remember, right? According to me, this is how the world looks, and the world is flat, and that's the way it is, right? But I would love for students to learn P&E, and then when they go do the neuro part, they can apply it to neuro. When they go to the pediatric part, how do I apply it to? That's if you really want to focus, but that will drive us towards things like residencies, fellowships that aim specifically in those directions for, and that's way more specialized training.
Excellent, well said. How does P&E improve the therapeutic relationship between a practitioner and someone living with pain? I think that's a really key part that we need to explore more in the research and to adopt more as professionals as well.
Yeah, we are literally doing that research. So my colleague, Dr. Corey Zimney at the University of South Dakota, just defended his PhD. I'm super proud of him. And his whole PhD looked at basically this thing at what makes therapeutic interactions work, and especially on the pain side. And it all came down to one word: trust. If a patient trusts you. And here's the cool part, Joe, for the clinicians listening today: trust is not time contingent. The studies have shown us more time with a patient doesn't necessarily mean more trust. You almost instantaneously, within a fraction of a second, develop trust. And now the question is, how do you do that? It's being present. It's the stuff you and I believe, right? I'm not looking at the computer, but how you doing? Being here, being present. What brings you here? How can I make your life better? I think the whole therapeutic alliance, trust, empathy, compassion, putting that around an explanation for something that has been making you afraid, nervous. But I would argue it's not just P&E. I think we've got to be careful, because I think a well-meaning biomedical explanation for something, you have a problem with your shoulder, but in this interaction, there's trust, compassion, empathy, etc. We are exploring it. How's that? There's the answer. We're exploring it. I think it's critical. I wish we spend more time screening students, the future professionals, on those skill sets as well. The compassion, empathy scales, whatever they may be. I've always asked academics, how do you find the next good PT? Well, they just have a standard list of questions. There's something, right? I know who I don't know who they are. I would like to know who are they? Yeah.
It's always been something that's fascinated me too. I've interviewed lots of physical therapists for jobs, and I've always tried to figure out, okay, what's the formula during an interview to ask people to figure out, are they going to be a good therapist or not? And I think that's true at entering the university setting as well. Effective delivery of PNA should change or modify thoughts and beliefs with regard to pain. Sometimes that happens. Sometimes it only happens partially. Sometimes it never happens. In your experience, I mean, in your years of experience in training professionals now in this technique, what's your recommendation or what's your advice, or how do you approach, let's say, a professional who maybe gets stuck on the idea that they have to absolutely change thoughts and beliefs for P&E to be effective and for them to be effective as a practitioner?
Yeah, this is a good question, Joe. I mean, I'll just tell you, in our group, there's two ideas here. One is to look at P&E as a technique, you walk in, I'm going to do this technique. But then there's a group of us that believe that P&E is not a technique, it's the way we do what we do. It's almost this idea that you filter it throughout your being in the clinic. And I'm very intrigued in that idea. Joe Neese, who's everybody knows is one of those Mr. Super bright, smart guy. We do a lot of research together. And when we sit down and have one of our favorite beverages, we always talk about this. And he said, we need to change pain neuroscience education to pain neuroscience communication, because it's the way we talk to people. It's not a technique. I think that's maybe what the essence of this stuff is, that we need to get away from the idea that it's a technique. No, it needs to become the language of clinicians. I mean, we're now doing work with medical doctors where they use P&E, with nurse practitioners, PAs, and it should become the normal language we have. And so maybe I'm not answering your question directly, but I think that may be the way we should be looking at this per se.
Another thing that I've been looking at more and more is what we've done as a profession, the PT profession, since the opioid crisis has started probably about 2016. I think we've had great marketing from the APTA and many professional organizations with regard to physical therapy as an alternative to opioids, and physical therapy as a way to prevent chronic pain. But I haven't really seen us step into that arena yet as professionals where we're directly involved with opioid use disorder. And I've kind of, stuck my thumb into people's sides a little bit and asked them this question, like, would you be comfortable working in an environment where you're either, directly treating someone or part of a team that's treating opioid use disorder? And some professionals say yes, but I think a lot of them say no, I don't feel prepared or educated enough to do that yet. Is P&E a way for us to start to engage into obviously this massive problem, especially in the US, with regard to opioid use disorder and with the tapering strategies that are now starting to happen in various places?
Yeah, it's a good question. So I'm going to give you two answers real quick. The first one is we have done work in that. We published a paper recently where a physician used P&E to taper a patient. Single case study, I got it. We have built basically what we consider an anti-opioid initiative with some of the VAs in the United States, where the idea of P&E Plus is you build such a robust therapeutic treatment tool that engages the endogenous systems that you can taper patients. So I can see where therapists are nervous and anxious. We've always been told we don't deal with drugs, but we have to put our foot in and say, you know what, I'm going to build this side of the scale. And then my doctor, my nurse, the PA, whatever, will taper the drug on the other side. It has to definitely get in there. That's one answer. That in itself, I think, is still a problem. So one of the initiatives we've worked on really extensively is we have built now middle school programs for P&E. We have to start upstream, Joe. Today's kids are tomorrow's adults. We just published a paper where we took 600 middle school kids, trained them in P&E. One group got it, one group didn't, tracked them for 6 months. And during school year, the kids that learned P&E used 30% less pain medicine during school year than the other groups. How will that translate later on? We must take this to the population at large. By the time they come to us in the opioid dependence stages, that's fine. We need to work with them. I'll give them everything I got. But if we don't change it from the beginning, we'll never change it. We got to go way upstream to change downstream.
I agree. These are difficult problems that sometimes persist in people for a long time, and getting to the root of the problem early is a wise way. Adriaan, I think that you and I and the people listening to this podcast speak a similar language with regard to physical therapists or physiotherapists can use the mind and can engage the brain with regard to treatment, but still not everyone. And some physical therapists haven't come around to the idea of cognitive interventions in practice. Some referrers don't understand how a physical therapist can use this. They look at us as very, mechanistic individuals. Why is it still considered a radical idea that physical therapists can use the mind and cognitive behavioral interventions in practice to help people?
Yeah, that's a good question. I mean, there's multiple answers. It's the models we follow. It's the legacy of Rene Descartes. It is. I think the biggest thing is, but when I hear from therapists that I don't do that, or I'm not going to go that way, I start laughing because you're already doing it. You don't know you're doing it. I've made many people better by what I tell them, but not by the technique I did. Those kind of things. I think. I don't push them. I leave them be. That's fine. Do your thing. We'll all get there. But I think the reluctance is the models. We need to significantly update the models we're teaching and understanding. Then there's the stigma, right? Oh, it's in my head. Oh, you think it's not real. All pain is real. I mean, I'm a neuroscientist. We scan brains, and I'm telling you, we've never scanned a brain and let's call it fake pain. All pain's real. And a message, if your patients are listening, if a provider ever makes you feel like you don't believe you, then fire them and go find somebody else because your pain is real. But it's leftovers from the models we were taught for years, very peripheralistic, leftover from years ago. But for the clinicians that think they're not doing it, I have a message for you. You're doing it. You just don't know you're doing it.
Yeah.
And that's the fun part, actually.
I agree. Adriaan, it's been a information-packed 30 minutes. And I can talk to you forever, but I know you have important things to do. And I appreciate you coming on and sharing your information and knowledge in this concise way and, really sending the message of P&E plus. I think that is the important message. It's P&A and everything related to the plus should help people move and engage with their life. How can people learn more about you and your great work and all the things you have to offer?
Yeah, I mean, the easiest way is our company, Evidence in Motion. One word, evidenceinmotion.com is where I work. We teach classes, we do seminars, we do webinars, all kinds of fun stuff. And if anybody wants to find anything we're doing, they can definitely find me there.
Great. I want to thank Adriaan once again for joining us on the Healing Pain podcast this week, talking about P&E plus. Make sure to share this episode out with your friends and colleagues on Facebook, Twitter, LinkedIn, or a Facebook group where people talking about pain neuroscience education, an important topic both for practitioners and for people living with pain. I'm Dr. Joe Tatta. Have a great week, and I'll see you next week.
Thank you for listening to the Healing Pain podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit Integrative Pain Science Institute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.